Today we learn about the topic that is the periodontal flap. It is a very important topic in perio. It is a star topic. This topic is most widely asked question in final year exams. So you have to know about the flap in detail, the indications, contraindications, and the classification, and the most widely asked question is the modified widman flap. So let us see about the flap in detail. So first we will start with the definition of the flap. So what is periodontal flap? It is a section of the gingiva or the mucosa that is surgically separated from the underlying tissues to provide visibility and access to the bone and root surface. So what is periodontal flap? It is a section of the gingiva. So for example, this is the tooth. Around the tooth, it is a section of the gingiva. This is a gingiva that surrounds the tooth. So it is a section of the gingiva. Or the mucosa that is surgically separated. So when we separate this and we raise this flap, so this portion is called as the flap. So it is a section of the gingiva or mucosa that is surgically separated from the underlying tissues to provide visibility and access to the bone and root surface. So why do we want visibility and access? That we will see in the indications. Visibility and access is why do we need it? Because the first indication is presence of persistent deep pockets greater than 5 mm. So after phase 1 therapy, so you have completed the phase 1 therapy, that is you have done scaling. After that you see there are deep pockets present, so we have to debride and remove the granulation tissue from within the pockets. So to remove the granulation tissue, we have to clean and surgically open the pocket to provide access to the root surface. Next is presence of osseous defect. If there is any defect in the bone, so we have to raise the flap to remove these defects. Presence of inflammation and disease at the base of the sulcus. So this is the sulcus base. So if there is any inflammation here, to clear this part we have to provide visibility. And access to this portion. And if there is bleeding on probing, furcation involvement. What is furcation? Furcation is this area between the two roots of a single tooth. So if the furcation is involved, if there is recession, and you can see that the furcation is involved, there is any infection, to check this out we have to raise the flap. Then any regenerative periodontal procedures such as bone graft, membrane. If you want to place any membrane, that is you have learned the most important, that is in guided tooth regeneration we place GTR membranes. To place these membrane, guided tissue regeneration, we place GTR's membrane. So to place this membrane we have to raise the flap so that we can secure this membrane in position. Next, for gingival overgrowth and asymmetry, if there is any asymmetry we can raise the flap. If there is periodontal pockets distal to the last molar distal to the last molar, if there is any periodontal pocket we will raise the flap and we will clear the pocket lining. Any other procedures such as crown lengthening, apexectomy, also we will need to raise the flap. So when are the contraindications when we cannot perform these flap surgeries? When optimum result is obtained by non-surgical procedure, when you are getting the desired result by just scaling, you don't need to go for a flap procedure. If you can see the inflammation, the pocket lining has reduced, so you don't need to perform the flap procedure. If there is any unprepared soft and edematous gingival tissues, if there is any unprepared soft and edematous gingival tissues, it is contraindicated, because we cannot, in this condition we have to first reduce the edematous tissues. If we go to raise the flap, we will not get a proper flap with a proper base, so it is a contraindication. Medically compromised patient, if the patient is medically compromised, if he is under chemotherapy or any other conditions, systemic conditions, we have to not perform flap surgery, because it may lead to delayed wound healing or any other complications there. Patients presenting with poor oral hygiene, if a patient is not removing the etiological factors that are causing the flap, that are causing pockets or inflammation in that area, there is no use of performing flap surgery, because the pockets may be reoccur again. Teeth with hopeless prognosis, if you have seen that there is grade 4 furcation involvement, there is no use performing flap surgery, the tooth will already go in extraction. When there is surgically, when surgery can result into extreme aesthetic disfigurement, we will not perform flap surgery. So now let us see about the classification of periodontal flap. So classification based on the bone exposure after flap reflection, you have two types: full thickness mucoperiosteal flap and partial thickness mucoperiosteal. So based on the bone exposure, when you take a full thickness mucoperiosteal flap, all soft tissue and the periosteum that is covering the bone is reflected, hence it reflects the bone, so bone is exposed. In full thickness flap, all soft tissue and periosteum is reflected, which exposes the bone. But in partial thickness flap, also known as split thickness flap, only the epithelium and a layer of connective tissue is exposed. The periosteum, it remains connected to the bone, so it is called as partial thickness flap. Based on the placement of flap after surgery, it is called as non-displaced flap and displaced flap. In non-displaced flap, you can see the flap is returned and sutured to the original position from where the flap was taken. But in displaced flap, the flap is placed apically, coronally or laterally to the original position. And for management of the papilla, there is of two types, that is conventional and papilla preservation. In conventional, interdental papilla is split means it is cut into two parts, and papilla preservation flap, in which the papilla is preserved, it is used in aesthetic zone. So there is three classification, that is based on, first one is based on the exposure of bone after flap reflection. Second is placement of flap after surgery, that is non-displaced, displaced. And third is the management of papilla, that is conventional, in which the interdental papilla is split, and papilla preservation, it is used in the aesthetic zones. So now let us learn about the type of incision. Periodontal flap involve the use of horizontal, that is mesiodistal, and vertical, that is apicocoronal. Mesiodistal is horizontal incision and vertical incision is the occlusal apical incision. Horizontal incisions are of three types, that is internal bevel, clavicular and interdental incision. And there are other incisions, that is vertical, releasing incision, thinning incisions, cutback incision, and periosteal incisions. So now let us learn about the most important topic, that is the modified widman flap. So everyone, Just remember, don't forget to write these notes. This is very important notes that you can directly, with diagrams, you can directly write in your exam, in your final exam papers. So first we will start with the modified Whitman flap. Modified Whitman flap, it was given in 1965 by Morris in the early 20th century. He named it as unpositional mucoperiosteal flap. But in 1974, Ramford and Nessel gave the name as modified Whitman flap. So before 1974, it was given by Morris in 1965 as unpositioned mucoperiosteal flap. So we can see it is described for exposing the root surface for proper malicious, that is proper instrumentation, and for removal of pocket lining. So it is not intended to reduce the pocket depth, it only reduces the pocket lining. So for example, this is the tooth and it has a deep 7 mm pocket. So this pocket lining, this inflamed pocket lining is cut out and removed, and this tissue, after cleaning, it is heals and it attaches back to the tooth. So this modified Whitman flap, it is only used for eliminating the pocket lining and not to reduce the pocket depth. It only reduces the pocket lining. So let us see the steps. The first step is initial incision, that is the internal bevel incision. Internal bevel incision is to the alveolar crest. It is 0.5 to 1 mm away from the gingival margin. It is given with number 15 BP blade. It preserves the papilla thickness. It follows the scalloping of the gingival margin. For example, this is the tooth, this is the bone, and this is the gingiva. So the internal bevel incision, it is given in this direction along the alveolar crest of 0.5 to 1 mm. This is 0.5 to 1 mm away from the gingiva. With the help of number 15 BP blade, it preserves the papilla thickness and it follows the scalloping of the gingival margins. For example, this is a side view of a single tooth. For example, if this 3 tooth is involved, so here this is the way it is given. So this, it follows the scalloping of the tooth, that is the gingiva margin. So after this is the second, is the gingiva is reflected. So first we will give the internal bevel incision, then the gingiva is reflected using Malt's number 9 mucoperiosteal elevator. So this is the gingiva that is reflected. After that, the second incision and the third step, that is the clavicular incision. It is given at the bottom of the pocket to the bone. So this clavicular incision, it is given in this direction along the sulcus. So this is the gingival sulcus. It is given along the sulcus in such a way that this, see, this is a tooth, this is the bone, this is the flap that is reflected. First you have given internal bevel incision, and then you have reflected this flap. Now this is the sulcus. So along the sulcus you will give clavicular incision. Clavicular incision, after giving in such a way, this triangular wedge of tissue is removed. It contains the pocket lining. This is the pocket lining and it is done with number 12 BP blade. So all of you will have understand. So the first step is the initial incision, that is the internal bevel incision. The second is to reflect the flap, and third step is to give the second incision, that is the clavicular incision. in which it is given along the sulcus of the tooth. And the third is the interdental incision. The third interdental incision is made on the interdental space and the flap is reflected. So this flap is reflected and removed cornel to the bone with a curette or an Orban knife. Orban knife, it is an interdental knife which can be used. This gingival collar is removed. So third incision is the interdental incision. After giving the 3 incisions, the tissue tag along the bone, you will see the tissue tags and granulation is removed with the help of curette. Root surface is this root surface, there is scaling and root planing is done. SRP is done along the root surface and all the residual periodontal fibers. So when you're removing the granulation tissue from the tooth, from the exposed bone, or when you're doing the scaling and root planing, you should keep in mind that the residual periodontal fibers which attach should not be disturbed. If while doing this you are even removing the periodontal fibers, that can increase tooth mobility. Hence it is not recommended to touch the periodontal fibers. The bone architecture is not corrected. In this procedure you are not correcting the bone architecture. The facial and lingual interproximal tissue is adapted back. After doing this procedure, this tissue which is raised is adapted back to the surface such that there should be no exposed bone. When you are suturing, when you are adapting the flap, it should adapt properly to the tooth surface. No bone should remain exposed. The flap is pulled and thinned to allow close adaptation. After this, you will give a continuous interdental sling suture are placed in both facial and palatal surface and cover the area with a surgical periodontal pack. So this is the step in modified widman flap. Let us revise it once again. Step 1, initial incision, that is the internal bevel incision. Second step is reflect the gingiva. Third is the clavicular incision at the bottom of the pocket to the bone, that is from the sulcus. The third incision is the interdental incision. This is the fourth step. The fifth step is removal of granulation tissue, scaling and root planing. The sixth step is to remove bone architecture is not corrected and the facial and lingual flap is adapted to the bone. And the seventh step is continuous interdental sling suture. So this is all about periodontal flap. We'll also learn about the different type of flaps that are used in perio surgery. For more information on this subject, please subscribe to my channel.